everyone.
Good evening.
Wow, wonderful. And my name is Professor Tara Dean, and for those of you who don't know me, I am the Provost for London South Bank University. It is my absolute pleasure to welcome you all to the inaugural lecture of Professor Calvin Moorley. And of course, for those of you who are joining us as guests, this is very typical of our inaugural lectures, and I would encourage you to attend all of them. The problem is, with that steel band, the expectation and the bar is set very high now. So, the presentation of an inaugural lecture is a significant milestone in the academic career of a full professor. The inaugural lecture provides an opportunity to present their career so far, introduce their field of expertise to wider audiences, and to update colleagues on current and future plans. For the schools where the professors are based, the event is a chance to celebrate the achievement of their professor across the staff and student body. And I really welcome staff and students from the Institute who joined us here today. It's also an opportunity to strengthen existing relations and catch up with alums. And I know we have some of you who have studied with us or have worked with us in the past. Welcome. And also to establish new conversation and collaboration. For the university, inaugural lectures represents an essential component of the public event program. They are a key opportunity to engage with general public, creating a wider awareness of the benefits of universities' teaching and universities' research. And as such, we are delighted to be restarting these inaugural lectures again in person after the COVID pandemic. Of course, meeting in person does feel very special. It really facilitates a greater richness of understanding, a greater flexibility of discussion in the post-event reception, and a greater gravitas for such an important milestone. Meeting in person also gives me the chance to rehearse that age-old introduction to any face-to-face meetings. I am sure we've all missed it. So here it goes. Please switch off your mobile phones. Keep in mind that we are recording this event. The toilets are signposted outside, and we are not planning a fire alarm test. So if the alarm does sound, please make your way in an orderly fashion through the exit there. I think you all missed that sort of introduction. So allow me to introduce Professor Moorley. Calvin, if I may. Calvin was born in Trinidad and Tobago and is one of 8 children. Excellent. He completed his primary and secondary education in Trinidad. He arrived in the UK in 1991 and started his nurse education in 1992 at the University of Essex, with clinical training at Colchester General Hospital. He graduated with a diploma in 1995. He then moved to London and worked at Guy's and St Thomas's Hospital, where he gained post-registration nursing experience in intensive care nursing. He's also worked at King's College Hospital, and Barts Health. Calvin actually undertook a degree in politics at Goldsmith in University of London alongside his full-time nursing work and graduated in 1999. His first academic position was at Lewisham College teaching on the Access to Nursing program. He then moved to higher education sector in 2001 as a lecturer at Thames Valley University, which is now University of West London. Calvin actually secured the PhD scholarship at University of East London. I'm waiting for excellent. And was awarded a doctorate for a thesis entitled Life After Stroke, Personal, Social, and Cultural Factors, an Inner-City African-Caribbean Experience. His postdoc was accomplished through the Mary Seacole Prize for Leadership in Nursing, exploring ethnic minority informal stroke carer experiences. Calvin joined us at LSBU. Woo! That's much better, thank you. In 2014, as a senior lecturer in adult nursing, and was appointed to associate professor in 2017. He was promoted to Professor of Diversity and Social Justice in 2021. Calvin is the only UK editor for the Journal of Transcultural Nursing. He is chair for the Chief Nursing Officer England National Shared Professional Decision-Making Council for Nursing Research. He is a member of Council of Deans for Health Anti-Racism Advisory Group and was instrumental in setting up the Council's fellowship scheme to advance ethnic minority healthcare academic staff careers. He's also a visiting professor at University College Dublin, School of Nursing and Midwifery of Nurses. Have I mentioned every university? I'm just worried that I haven't mentioned all your external examining. His research interest is in the area of ethnicity and health and the interplay between gender, culture, and ethnicity on health. And I know that we are all looking forward to him sharing some of his research finding with us. I'm slightly nervous that next to me there is a sandwich. I am not quite sure what is meant to happen to this, but I know Calvin's sisters are in the audience, and they want to show whether they be hungry throughout his lecture. So perhaps he's got this for them. So what can I tell you about Calvin as a person, outside of his academic achievements and esteem measures? I have not been here at LSBU that long, 8 months in fact. But it has been an absolute pleasure to work with him. My first proper interaction with him was when I was delivering an academic promotion workshop for our BME academic staff. Calvin joined the workshop as a recently promoted professor to share his learning and his experience with the group. And I witnessed firsthand his commitment to supporting and nurturing colleagues through their careers. Since then, almost every early career and middle career researchers I have spoken to at the Institute of Health and Social Care seems to have been mentored or have sought advice from Calvin at some point throughout their career. Now, supporting colleagues and mentoring colleagues takes time and effort, and it is not often recognized as it should be. And I wanted to publicly thank Calvin for all his effort in supporting others. Outside of work, Calvin has a deep-rooted commitment and passion to shoes. In the words of one of his colleagues, It is all about the shoe, the whole shoe, and nothing but the shoe. So please pay attention to his shoes. Then I invite him to come across and deliver his inaugural lecture. And of course, I couldn't introduce Calvin without mentioning his Friday night comedy gems on Twitter. Calvin has nearly 10,000 followers. I'm quite envious of that, if I may say so myself. But Calvin's tweets on a Friday evening brings a smile to me, and I'm sure it does to all his followers. Let me share a couple. What do you call someone with no body and no nose? Nobody knows. Why do ghosts love elevators? It lifts their spirit. Another one? One more. I wrote a song about a tortilla. Actually, it was more of a rap. For more, please follow at Calvin Moorley on Twitter. But seriously, he is a great colleague and an inspiration for his profession, students, and staff. And we are extremely proud that he has chosen LSBU as his academic home. So please join me in giving a big welcome to Professor Moorley to deliver his inaugural lecture.
Thank you, Tara. Thank you very much.
Pleasure. Thank you.
Thank you, everyone, and thank you for coming. Thank you for that introduction, Tara. Most of you know him as at Mr. Calvin Moorley, but Nick is here and he'll tell you how bad my jokes are at home as well. But thanks for that. So thank you all for coming to share my inaugural lecture and some of my findings from my work and experiences of actually working with colleagues. Today I want to talk about nursing while black, and it's not why racism is killing nurses, because I think most of us know what racism is about and why racism occurs. It's because of that deep hatred of black people and that fear of black people and what that may bring. So my take today is to say, well, how is it actually killing people? We know why it occurs, but how is it happening? And I want to look at the very micro levels of racism today, of some of the stuff. Hope I'm going to do this right. Great. So nurses, registered and unregistered, they form the fabric of the NHS workforce. They do most things. They've been described lately in the media as angels, a term I'm not comfortable with, because I see nurses as being degree educated, from degree to PhD level educated, and they're highly skilled professional who saves people's lives and help to work for good outcomes for patients and public. So my talk today is all about, in three parts. It's an explanation of what I call the house of racism that exists, and an exploration of the three rooms. I'm going to just take you through three rooms. There are lots of rooms, but three rooms I want to focus on from my work. And then I want to move a little bit towards international nursing recruitment, something I'm very concerned about, at how it's being operated in this country, and the ethical side of it as a new slave trade, and how we need to approach that as nurses. So everyone knows the structure of a house, and this is the house of racism. And from my work, if anyone had the opportunity, I had a great opportunity to deliver the Mary Seacole lecture last year, something one of my mentors and very good friend, Professor Laura Sarant, who is here tonight, she also delivered. I have to say, when I met Professor Laura Sarant in 2012, I was just awarded my doctorate at one of the RCN scientific conferences. Laura was the first black professor I ever met in real life. And I was like, oh my God, black people actually occupy this space. I could probably become a professor one day. And here I stand. So Laura, thank you so much for your mentorship and guidance and leadership in this space. Thank you. So, as I was saying, if anyone ever listened to my Mary Seacole lecture, I talked a little bit about the slave trade and slavery, and that's to do with colonialism. And the islands that I come from, or I come from Trinidad and Tobago, the whole string of Caribbean islands, we were colonized by the French, the British, the Spanish. So we have colonies. And what colonialism really did was building the British Empire. And people like me, our ancestors, we come from slave ancestry. And what colonialism did, it based on, if you look at the slave trade, which I think most of us hopefully here know, I'm not here to teach you the slave trade, but it was a triangular trade that went from Europe to Africa and then back to the Caribbean. And it sold people. It captured Africans and sold them. What's important to understand about slavery is that it actually broke up families and lives. When we experienced COVID recently, we thought we weren't able to see our families and we had to see them through screens or just through a window, and that was quite traumatic for most of us, or everyone probably. But what colonialism did is it captured families of Africans and it transported them to the Caribbean. But it was a trade, and it was selling people, it was selling humans as commodity. So what it did was you'd have a family of a husband, a wife, and 2 young sons, for example. And they would stop in Barbados, and they will sell probably the father there. And by the time they get to Jamaica, they will sell the mother. And one of the sons may be in Trinidad, and the other may be in Dominica, for example. So families were split up. And they didn't know each other anymore. They didn't know what happened. So colonialism, the foundation for the House of Racism, builds on colonialism, because what colonialism teaches us was that black people were to be dominated by white people. Black people had a space, but it was a hierarchy, and they were at the bottom. So, and this is why this really resonates. If anyone looked at the latest RES report, the Workforce Race Equality Strategy, Professor Anthony Manuel now took that over from Yvonne Coghill. What it shows is that black nurses still occupy the lower hierarchy of the NHS and the whole system. So there is some work to do there, colonialism. So, but a house has a structure, okay? It has the roof and the 4 walls, and in order for it to keep its structure, there in the House of Racism, there's laws and policies. So that's where I bring in my take on structural racism. And structural racism begins to occur here. So through laws and policies, we begin to see how structural racism occurs. It's those laws that keep people together, or keep people out, for example, I should say. So you had, stop and search. That's something at a very macro level, okay? You have policies. So one of my examples is, I've always said to people, when I worked as a nurse in intensive care full-time, we had a manager. She'd always come into the staff room for lunch, at lunchtime, and make a comment, "Oh, it smells of food in here." But always when the ethnic minority staff were having their lunch. But there's a microwave and you heat your food. All heated food smells. And she said that for about 3 weeks, and then I went away on holidays and I came back, and there was a sign, "No heating of smelly food in the microwave." Policies, yeah? Little local policies. This is how nurses are being ground down. So you can't take your own food anymore into work. And that's one of the things. So, but there's also guidelines and rules in the house, okay? So when you enter the house, you need to look at what these rules are and how they perpetuate racism. So let's look a little bit at this. One of the things that racism do is that it tells black people they're not good enough. It tells us we don't belong here, we don't have a space here. And if it is, it's always at the lower end of the hierarchy. What that does, that becomes internalized. So it becomes a bit of a health sacred. So in the castle of my skin, I know who I am. And a castle really is a fortress. It protects people. So our skin should protect us, but my skin, when I walk out, signals that I am different. It signals that I am different to anybody else because they see black. They don't see the norm, which is white in the country we live in. So our skin signals that. And what structural racism does is these experiences, we begin to internalize it. And what we begin to do is we begin to think that, okay, I'm not good enough. And it's overt messages when internalized racism becomes. And they're subtle, and it reinforces negative beliefs that, as I say, we're not good enough. Why am I keep going for this job? Why do I not? And why do I not get it? And one of the things nurses in clinical practice we often hear when you've gone for a job is, and you didn't get it, is that you weren't good enough because on the day, or we really liked you as a panel. And if anybody ever heard that statement, you can put your hand up. Well, as a panel, we really liked you and we enjoyed your presentation and your interview. However, the other person was able to run with the job. And I'm like, if you like me so much and you think I can do the job, just employ me. And you can mentor me and train me for 6 weeks or 3 months, and I'll be able to run with that job. But there's another thing we're told, is that we must be resilient in nursing to succeed. I personally don't like this narrative. No one should have to. We're living in an economy of nursing, in this ecosystem where particularly black nurses are told over and over, you must be resilient if you want to get anywhere. And this is a false narrative. It's a narrative that shouldn't be there. But I want to leave that for a second and talk to you a little bit more about. So I'm a nurse and I'm a nurse academic, and those of you who know me, as Tara said, and you follow me on Twitter, you know I still work clinically. My wonderful clinical colleagues are up there in the back. Thank you for coming. And that's really wonderful, because in work, when we get those moments, we sit down and we have those conversations. And we talk about racism and we talk about how things operate. And it's wonderful that as nurses we have that opportunity to do that. But we were nurses, and I want to just move slightly to when nurses move into academia, okay? University settings are no different, okay? They're no different to hospitals. We're both large organizations. The NHS is a large, complex organization, and so is the university. So one of the reasons I think we face so much racism in academia, nursing academia, is because we transferred. Anyone who's a nurse academic understands you get to a certain point in clinical practice and then you transfer over into academia. And we transfer those same NHS values. We don't reintegrate into the university setting, the academic setting, and those values 100%. So we bring some of the NHS isms with us. So some of the things that we face as black academics, nursing academics, is, for example, if you had an all-black PhD supervisory panel, a lot of the times you're not trusted that 2 black academics could actually supervise someone to a doctoral level and they'll succeed. So a white person is put in there, not needed at all, but they're put in there because they will monitor you and see what you do, and they will keep you on track. Did you send that email? Did you do this? And they will keep you on track. And the thing is, if you slip up, they will use the rules of the house, the structural racism, to make sure you've slipped up, okay? So the rules will be applied in terms of structural racism. Well, you didn't do this right, and you didn't do that, or you didn't do it on time. So there is that thing. Similarities in clinical nursing practice. For example, an ethnic minority nurse in charge of a shift. I remember my days being in charge, and you'd be questioned so much by your white colleagues of why you made that decision, why you didn't do it. And the questioning is that it's the challenge of why you made that decision, that person doesn't have faith in you, that you were able to do that. So there is a similarity between both of these situations of academic clinical nursing and clinical nursing, is that people who are non-BME colleagues, they are praised for trying, they're praised for stepping up. Oh, well done, you gave it a shot. He is young, but there's this whole thing. But what really happens is, and they're told it's a learning curve, you'll do better. If the tables were turned, the BME staff are seen as reprimandable. Why did you do that? You'll be slapped down on the knuckles as such, you'll be rapped, and you may even be referable to the NMC, which is, for those who don't know, the Nursing and Midwifery Council, our regulator for nurses, midwives, health visitors, nursing associates. And we know that there have been a lot of cases referred to the NMC, and the data shows us that hospitals are more likely to report a black nurse for what we call fitness to practice at the NMC. And a patient is more likely to refer a white nurse. We also know, and thank you, Andrea, I'm not drawing attention to you, it's nice to see you here this evening. And we also know that, black nurses are more likely to go on into the full fitness to practice investigation at panel level and have impositions put on them as such for their practice. So there are these things that, and it's sometimes, I'm going to say, it's because of the racism that occurs. But this whole idea of internalized racism, that I am not good enough, it sometimes comes from within, and it starts with our families, because those of us whose families were migrants here, and most West Indian people, and I'm talking from the West Indian aspect for a little bit, the Caribbean aspect, our families came through the Windrush generation. And really importantly, Windrush was a SOS call from the British Empire to help build back better as such. And our families who came here, they actually experienced racism. And very interestingly, the Prime Minister at the time, Clement Attlee, had a letter written about the threat of black communities to white England. So there is this fear of black people. There is this fear that black people can do something to white people that's negative. There is this fear that black people are inferior, that they're less educated, that they're not able to perform when we can. But our parents who've experienced racism and what it was like for them keep saying to you, to us and our siblings, you must be 100% ahead of the white person and their game. It's told to us. You must always try and be ahead of them. And my take on this really and truly is that we shouldn't have to be ahead. In reality, the system should be equitable. And this is where part of my work with diversity, equity, and inclusion comes in, is that we should be equitable to help people achieve their potential to become the best that they can. Or put in another way, does organizations like the NHS and the HEI sector believe they have a problem? Do they believe they have a problem with racism? And are they, after they believe they have it, are they ready to face it head on? Are they actually ready to see what's in front of them? And I have learned a lot from chairing this university's Race Equality Charter, because we see where the problem lies. As I said, universities and NHS organizations are very complex places. So while you may have rules and policies, people at other levels make their own, okay? So you have middle managers who will make their own policies, unknowing to the other people, and that's how it begins to take place. So just to end off this little bit of this room is that your castle is your skin. As I said earlier on, your castle is like a fortress, and so racism no longer needs to be internalized and become self-harming. Our castle should protect us. Our skin should protect us. So just moving on to room 2. We all saw this. Enough is enough, I can't breathe. These are synonymous with the Black Lives Matter movement. And Black Lives Matter is not just a simple statement that we say, oh, Black Lives Matter. Yeah, Black Lives Matter. It's actually about the histories of black people. It's about the policies that go back to slavery days, as I said. Black Lives Matter contains a number of things within it, that statement. It's about contemporary and historical experiences of racism. So when we use that term, it's not just a simple term to say, oh, Black Lives Matter, it's okay. It has more to it than that when we begin to unpack it. So within this room lives one of the things I want to talk to you about, I said, is on a more micro level of how racism exists and affects people. And I wanted to make it a little bit interactive because I don't want to be the only one talking for a while. So I'm just going to ask, 3 or 4 people to shout out can you give me an example of a microaggression? Anybody at all?
Where are you really from?
Where are you really from? As a nurse, I've had that a lot of time, okay? Anybody else? Patrick.
Is your hair real?
Is your hair real? Georgina Cox is here. She's written a bit about hair racism, so she can tell you all about that. Yeah, is your hair real?
Yes.
Okay, Georgie, your hair is real. Thank you. Anybody else could think of a mic? Shaminda?
You speak English well.
You speak English well. Yeah, it's really common. We're going. Anybody else want to?
That flesh colour of plaster.
The flesh color of the plaster.
They call plaster flesh.
Okay.
Obviously, for a darker skin, it's not.
Yeah. Okay, so the flesh color things, that's just made for white skin tones rather than darker skin tones. Someone here?
When you finish your training, will you go back?
When you finish your training, will you go back? So it's, yeah.
Are you a real doctor?
Are you a real doctor? Okay. One more, yes?
I've got something to say, but I don't know if it's a microaggression, but I'm a student from Bristol University, and I'm only 5 of minorities there, and I'm doing a master's in psychology of education. And for example, when my teacher used to talk about slavery or blackness in general, everyone was looking at me, expecting me to have a reaction. It's very uncomfortable. So that has an impact that counts as microaggression.
Yeah, because they think because you're black, that's aligned to you. Yeah, and it may turn out that you're not even born here, you didn't experience that, and etc. I mean, you're born here rather, and not migrant in. So there are these microaggressions that we hear every day, and there's some of us, that we sit back and think, we actually hear ourselves saying it. Oh, they're really good, but, or they're really good for, and that's to do with race and racism, the other side to it. So there are those things with microaggression. And what microaggression really do, it's a common form of racism. And this is the thing, the law is not set out to prove microisms, all of these things that affect racism. So the microaggressions, the law is not set out to prove it. It's all within context, and we talk about that a little bit later on. So it's when you use words or actions and you look to racially aggress someone from a ethnic minoritized background. Sometimes it's direct, as some of you have experienced. Sometimes it's indirect. The first time I became a British citizen and I came back through the immigration queue, they didn't have the electronic passports then. The woman said to me, how did I become a citizen? I was like, the normal channels? Is there another way? How else? I applied. Are you insinuating something else? I think she kind of picked on the wrong person to ask that question. So microaggressions, they can be behavioral, they can be verbal, and they occur. And I think as nurses and those of us who work in health, we have to be really careful that we're not microaggressing people unknowingly, that you don't realize it happens. So the result of a microaggression is that, yes, it communicates aggressiveness, it's hostile, it's unfriendly, it's offensive, and it's belittling to people from racial minoritized background. So there's another thing that's called microassaults. They're called old-fashioned racism. So we had the microaggression, and then there's microassaults. And these are the things that happen every day when nurses go into practice. The microaggressions, the microassaults, okay? And that's why I've talked about how racism is killing this, is because they carry this burden every day when they're in work. So microassaults, old-fashioned racism, so we're going to do the little thing again. Can anyone give an example of a microassault you think a nurse may encounter?
I don't want her looking after me.
I don't want her looking after me. Okay, so that's one. Thank you. Anybody else? Yeah.
On top of that, when you tell your manager, then they remove you from the taking the care of the patient. That's actually made quite a discriminatory comment.
So when you take it to your manager, they remove you because you're the problem. You're seen as the problem, not the other person. Okay, so that's a common one they say. Yes, Michael.
They're too, you get a relative who say they're too old to change in terms of their views. I just think, no. But that's often that's used as a rationale.
Yeah, or the one I often hear about relatives being too old to change is, but in my day we call them colored. In my day, we call them colored. So, it's age, it's nothing else. Okay? So we need to begin to look at that. Anybody else wanted to say another micro assault before I move on? Yes?
Instead of agree to disagree. Oh, you're being aggressive now. You're being aggressive.
Yeah.
Disagree with the statement.
So, if we don't agree with a statement, and we know that's coined really well in the literature, particularly around black women, they're seen as aggressive. Yeah?
Why are you shouting? Yes.
Why are you shouting? Okay. I saw one hand went up somewhere here.
Yeah. When you try to be assertive, to express yourself, they say to you, oh, you are aggressive. That's aggression.
Yeah. I should say Geeta was one of my first ever nursing students at what was Thames Valley University. Thanks for coming and supporting. And she's done really well. We've had lots of conversations about this sorts of stuff. So they are what, as we said, the old-fashioned acts of racism. And, and some of that is actually things like what we have even witnessed in society. Some of those assaults, they're not micro, but the killing of Stephen Lawrence, the murder of Stephen Lawrence, Damilola Taylor, George Floyd. Those are assaults because you are black, because your skin signals you as different, okay? So what can be termed, they occur on individual rather than group levels when you look at the micro level bit, okay? And it's something that's deliberate, somebody thinks of it, and they set out to harm you. And as I said, it can be name calling, they can be purposeful action that actually lead to racial discrimination. And then there is, within this whole room, there is a communication that interpersonal racism, which is another part, which is micro-invalidation, when someone sets out to invalidate who you are or your position. So communication that humiliates a person's racial identity and heritage. So I know Shabi's here. We used to work in the same intensive care unit together, and we had one of our colleagues. He said, in the end, he ended up making it a satire. He used to say, "I'm British," because every patient used to ask him, so where are you? And he used to say, "Well, I'm British. My passport says I'm British." And he walks around and says, "I am British." But there are people who will ask you, and it's about humiliating you. It is about telling you you don't belong. What you are, and if you don't belong, then you're not entitled to. Okay? So they have to look at all of those other things. So those include an example when a white colleague asks you how you got your job.
Another one is you must have blue eyes.
You must have blue eyes. Thank you, Joan. Yeah. So there is that idea that, how did you get your job? How did you get here? Josh Ferrante is in the audience, and Josh was one of my students here at LSBU, and he's now a lecturer, and he'd tell us how hard we worked together to get him to become an academic or get his first academic position. It wasn't given to you like that, was it? You had to actually earn it. So there are this myth that people think that we actually are given things for certain reasons. They think it's affirmative action. So someone may tell you, you've awarded yourself your title or your position. Are you sure you're a Professor Calvin? They may tell you, when you have been through a recruitment process, or sometimes what you find in certain jobs, you would have been promoted to a senior level, but the manager will call you in and tell you, actually, we're going to still pay you as that, but we need you here. So you're never going to get to do that job that you're actually employed to do or appointed to do because you're kept down. And these are the decisions, again, if we come back to the house of racism, when you open that door, the local policies and guidelines that the middle managers make up in the very complex organizations who don't always keep an eye on what's going on. Okay? And those are the grinds. So, commonly heard by most ethnic minority staff is another one, is that the most qualified person gets the job regardless of race. We've heard that. And there is a subtext to that comment. It's that ethnic minority people are not qualified to do certain jobs. I remember working with Nurse Watson, And she was Jamaican, and she said, when I qualified, they told me, oh, you can go and work with, and this is terms they used back then, you can go and work on the geriatric ward. She said, that's what I was told, because that's where black nurses go to work. And she said, but I went and I proved them wrong. I got a job on the private patient wing, you know, and that was a big acclamation for her. So there are those things. They tell you you don't belong. If you did not attain your position based on your ability and your merit, then you got it some other way. People actually think, and when we are black nurses and professors in certain positions, okay, people think that it was really handed out to us. Like, yeah, they just give it to you like Smarties. Actually, in fact, as I've said before, we worked doubly hard to get there, to prove that point and prove ourselves and get where we are. So recently I was examining a doctorate, and it was a terrible viva, and we had to have a break, because that's the university's policy, because it was going on for more than 3 hours. And the examiner, the supervisor who was sitting in the examining room, followed me to the toilet and said, I thought you'd have been much easier. He appointed an all-black panel for a black candidate because the work wasn't that good. But he actually followed me in and said, I thought you would have been much easier. So even when we are in positions of senior leadership, people think that, you know, we have really lower standards and that we will just let things slide. And that's really the opposite of who we are. So there's that thing. But as I said, there's a note for the Nursing and Midwifery Council and the Royal College of Nursing as one of our largest unions, is that when we look at these microaggressions, the micro-invalidations, the micro-assaults, what people have come back to me and have been saying is that and a lot of people contact me via direct messaging on Twitter, and they say, Calvin, I contacted the RCN, but they said I haven't got a case because the law says. And when microaggressions are applied in context, they actually tell a very different story of racism. Racism is very different to proven law, okay? But when you apply context, and so these organizations, when nurses are put before the NMC for fitness to practice, we really need to work with the NMC and say, these are what microaggressions look like. This is what this sort of stuff, and this is where it belongs. So when your panel sits, they can actually see how this plays out in real life, rather than going to a lawyer or the legal person on the panel, which is you have to do as part of process, and they say, oh, but you know, the law says. You actually have to apply these things within context. So it's really important, because the burden of proof for racial minority people, as I said, has to be proven by a panel. And most of these times, the panel is made up by white people. Now, I have, I said I, and I know other people who've applied to be on some of these panels. But even if you went to the Nursing and Midwifery website, and I know this is changing, Andrea, you would have to do these little tests. And those tests, psychometric tests or whatever you want to call them, are really colonized tests. So as a black person, I don't think that way. And then you score really low and they say, okay, no, you can't be on the panel. So we really need to change the system, because these are the sort of racism, and they'll come back to the policies and laws in the house that's killing nurses. So there's another one, gaslighting. I first learned of gaslighting via Twitter, I'm being honest. And I had to really, and when I got the principle and the theory behind it, I was like, oh God, that's just so common. It's concerned with making BME nurses question their worth. It undermines their judgment, and it makes you doubt your own experience. So I say, even when we're in certain places. So gaslighting is quite important. I'm just going to say, anyone, while I have a drink of water, anyone want to give me an example of gaslighting, if you have one? Go ahead, please.
I asked the deputy manager for some advice when I was going for an interview for a deputy manager post, and she said, no, Jen, I don't think you're ready for that yet. You're too quiet. You don't speak up in meetings.
Somebody said to Joan Myers, she don't speak up. Yeah, and I witnessed one recently. One of the nurses was told, the job you're doing, we're going to make it a full-time position. So the managers called him in, And they sat down and they did the job description and everything. And then it was put out. And we appointed somebody else to do the job that you were doing. And that person is much more junior to you, but we'll also like you to mentor and hand over to them. As I'm hearing lots of groans, so you know where I'm going. These are the micro-isms that are actually killing nurses, because then you lose interest if I cannot be rewarded. So I'm hearing some positive remarks. So what gaslighting does, though, it shifts the focus from the accuser, and it becomes a form of psychological abuse. So, Neil, I'm going to say I have to go into. So I'm going to give you all a poll. So you have to get your phone out. There's a little bit of interaction. And from what I've spoken about, the microaggression, the microassault, the micro-insult, the micro-invalidation, the gaslighting, if you go to pollev.com/Calvin Moorley 505, you will need to vote. And it says, can you order the interpersonal racism you have experienced with the most common at the top? So this is a bit at the top you're going to say, okay? pollev.com/Calvin Moorley 505. Okay. So microaggression. It's changing. It's like being on the television thing when you're looking at stuff, right? So microassault and micro-invalidation are coming together. We're still changing. It's great to see how people are voting and it changes, right? So microaggressions, I think, is number one. As you can see, we all have done that. There is something about micro-invalidation as well I wanted to point out. So for those of us who are black professors and work at universities, our salaries, we all know how that's calculated and done, and we have to bring in X amount of grant money and income to see our pay rises go up. And the UKRI recently published in their letter to Sir Norman Lamb that said, actually, black professors don't capture grants. But if my managers at the university don't understand that, and they don't value my position, my pay rise is very minimal, because I didn't get it. It's not that I didn't try. I didn't capture it or get it. So it's really important as well to come back to those structural racism. Why is it? So here you can see, I said this was just to see what people have experienced in the room. Some people have experienced microassault, gaslighting, yes, micro-insult, and micro-invalidation. So when somebody invalidates you, that's really psychologically harming, okay? Because it tells you don't exist. Your position is not who you say you are or what you should be doing. And that's important for us. I'm just going to go back to the presentation. I use a Mac, that's my excuse, okay? Anyway, we're back. So I wanted to leave the House of Racism. There's one more room I want to come to the end. And I want to talk a little bit about international recruitment of nurses. And this is my perception and some of the work I've done with some of the nursing associations that have been set up. And I see it as a transition from humanity to commodity. Nurses, we always talk about nurses being human and the caring and the kind, considerate side of nursing. And we're really and truly, when we look at international recruitment, it's echoes of slavery. It moves us to a commodity. And this is how I work it out. There are lots of similarities to the slave trade. The team, the slave traders, they ventured to other lands to seek out nurses, which were the slaves. The prospective recruits are made promises of visas, good working conditions, which is equivalent to the battering that goes on with slavery, okay? It should be battering, not battering, I'm so sorry. My fat fingers, that's all I'm going to say. And then nurses, humanity is later on transported, the commodity we become, to the UK, which is similar to the transportation of slaves. The commodity arrives, and passes immigration and customs, which are the slave officers. And then they arrive within the hospital. And anyone who have worked with any internationally recruited nurses, you have heard the stories. Anyone heard any of those stories? Yeah. Some nurses will tell you they have 4 weeks in accommodation, and then they have to find their own. But during that 4 weeks, they haven't passed the OSCE yet, so they're not a band 5 nurse. They're paid a HCA rate, and then they still have to find accommodation. Most of them are running 2 households. The prospect of earning more money sounds good, but in real terms, it's not that good. So there's a lot that happens there. They're treated as a commodity. And I think my view is that it has to be ethical recruitment of international nurses. I recently saw on social media someone pop their passport and their boarding pass, and they said they were off to Trinidad to recruit mental health nurses. My work with my home country, Trinidad and Tobago, the University of the West Indies, we're very technical back home. It's Chapter 1, Act 29 of the Nursing Personnel Act says, these are the qualifications to be trained as a nurse. And we were working on how we got the Nursing Council to change the entry criteria because Trinidad is in a deficit of nurses. But yet somebody from England was going to recruit nurses from Trinidad to England. So we actually go to countries that are in deficit. Countries who have changed their entry requirements and changed their systems of nursing. So you come in rather than be a 3-year RN program, it'll be a 4-year because you have to top up before you actually get onto the RN program. So it's like a fast track access almost for a year. But we had to change all of that just to make sure the country has enough nurses when we forecast. So I think we really need to be careful. I applaud the CNO of England because she set up some wonderful schemes for the diaspora nurses to set up. So we have the Caribbean Nursing Association, there's the Kenyan, there's the Nigerian, there's all these different nursing associations. There's the Filipino Nursing Association as well. But they're all administered by the Florence Nightingale Foundation. Again, there's some similarities to slave administration. Okay? The initiative is great. I like it. However, the nurses has to be catapulted and it has to be fully actualized, and their lived experience and voice must be at the table, because what they're saying in their associations is, these are our experiences of the hospital. This is how we are treated, but I don't know if it's getting beyond those walls of their little wonderful association that supports them. So it's really good. At that level, they have support, but nothing is changing actually their situation. And that's what we need to happen. My final thoughts on international recruitment of nursing is that the practice is already here, okay? But the theory will follow. And we need to make it a good theory, not like the slave trade theory, because we're still reliving what's happened with this. We're still living with even what's happened with the slave trade. So we need to make this theory of international recruitment of nurses really and truly one that we could uphold and say, yeah, we were part of it, and we put our hands to it. So my final room. I wouldn't stand here without white allyship. White allyship is really, really important. And it's really important to understand not all white people are racist. They really aren't. Yes. Thank you. Yeah, not all white people are racist, honestly. And so white allyship is really important to us in nursing. I want to say some thank yous. And I don't know if Professor Una Scott is here tonight. She said she was coming, but Una was my director of studies for my PhD. And I remember going home one night and saying to Nick that I had a lesson in nouns today. Una taught me about nouns. And what we were discussing is, do I say black with a small b, a common case b, or black with a capital B? Because it's a noun, and it's a proper name of a person, place, or thing. And she taught me that. And Sharon, I remember when I did my first transcript, I wrote it all in standard English, and you told me I just whitened the black woman's talk. And those things you learn. My PhD was supervised by 3 white women. But so what I'm trying to say is that, there are allies and there are people who understand. You know, I worked, I can see Denise, Val, and Grace. We all kind of worked in the same office at TVU. I mean, Denise, you taught me everything I learned really and truly in academia and nursing. You know, how programs are written and outcomes and learning stuff. So I appreciate that. So there are white people who understand and they get it. When I talk to Professor Mark Radford at HEE, I know Mark gets it. He understands what's happening with nurses. When Andrea sees an email in her inbox from me, she must think, my God, what is he on about again? But I know you get it and you understand it. So there are, you know, as I say, some people. Professor Leslie Bailey, I am ever so grateful to you, Leslie. You are wonderful. I came to LSBU knocking on the doors of certain people every week saying, I need a PhD student. And Leslie just found me, and everything I learned about supervising PhD students, it was from you, Leslie, and I really thank you for that. You have been absolutely wonderful. And there are lots of other people I could thank, you know, but these are just some of the people that come to mind. So white allies, they rise above silence. They confront racism as it raises and it occurs. Sometimes they're not always vocal. You may think, well, why didn't this person say something? But they will go back and they will think. And they may send the email, or they may call someone else and have that conversation. So it's really, really important to understand. Sometimes you think somebody didn't speak for you. You may not understand what they were doing or thinking at the time. What white allyship seeks to do is to deconstruct its institutionally racism and operate in a manner that challenges that systemic part of the oppression. But white allies themselves are at risk of experiencing some of that oppression because they're labeled and they're branded, okay? So, you know, they will be told, you know, what type of lover you are, you know, why do you do this? So white allyship entails building relationships with both people of color and also with white people to be able to challenge them in how they think about race. And I think it's really important that we all find our allies. And white allies hold the door open for us. They actually, and they invite us in. They don't only hold the door, they actually take our hands in and you know, they invite us in. So it has a place. What I really see white allyship doing is helping minoritized nurses to put their roots down. That reconnects their work with the British world that marginalizes them. Our work is nursing, and nursing is caring, okay? And our patients always come first, as we say. In my early days of clinical practice, Nick will tell you he's hung around in hospital corridors more times waiting for me because I'm going to be late, because something happens. Our work always comes first as nurses sometimes. But what our white allyship could do is help us to reconnect that love and passion we have for nursing with this British world that tends to marginalize us. And it's really important to understand white allies don't have it all figured out. They know it's wrong, and they may not get it right sometimes, okay? And that's really important. But what they're committed to is ensuring it doesn't happen again and that things move on. So white allyship is a process and a journey that we're all on, and it's a journey of learning. And I thought, I'm looking at Neil. This is just a normal slide, right, Neil? I had everything embedded, sorry, I should say to you all, and the polls didn't work. So I wonder if anyone could help us describe white allyship using a single word. Those of us who've experienced white allyship. I wonder. Any single word?
Present.
Respect.
Courage.
Courage. Thank you, Nicole.
Friend.
Friend. Okay.
Supportive.
Supportive.
Andrea. Andrea.
Okay, Andrea. Andrea is an ally. Okay, we know that. Yes, Paul?
Decentering.
Decentering. Yeah.
White mansplaining. It's 2 words, but it's
Okay. White man's.
okay.
White mansplaining. Oh, David Ring. Hello, David. Anybody else?
Upstanding.
Upstanding from bystanding. Yeah, from being a bystander to an upstander.
Loyal.
Loyal.
Champion.
A champion. Thank you.
Courageous.
I didn't hear that one, sorry.
Courageous.
Courageous. It does take courage to stand up.
I said depth.
Depth. Okay. Anybody else? One last one? Who wants to have the last word?
Present.
Kind and
Present.
present. Yeah. So I'm more or less at the end, and I wanted to thank you all for coming tonight. So what next? As Tara said, we share our plans and our vision for what we want to do. I believe in Martin Luther King. We think big and we dream big, and tomorrow is going to be ours. So in September, I will be launching the Dame Elizabeth Annual Lecture for Inclusivity in Nursing and Midwifery here at London South Bank. Yeah. We will have 5 awards for postgraduate certificate in leadership, and the projects around that will focus on inclusivity in healthcare practice so that the NHS, the healthcare sector, is built back, okay? So it's really important. And this is the dreaming big. It's the Calvin Moorley Center for Inclusive Practice. From pedagogy straight to practice, bringing together multidisciplinary working, collaboration, research, and I have a really big dream of following the American way of black colleges, of setting up the first UK Black College of Nursing. And this is not about being separatist, it's about understanding the position of black people. So thank you all very much. Thank you. Thank you. It's out there.
Thank you so much, and I haven't said anything yet. Rapturous support. So good evening, everyone. My name is Dr. Marcel Moncrief-Johnson, and I'm the Chief People Officer here at London South Bank University. We've just heard Professor Calvin Moorley's inaugural lecture, and he's given us brilliant insights into his perspectives. And can we give Professor Moorley another round of applause? Now, I know I'm standing in the way of refreshments, but I wanted to give some closing remarks tonight. So we've learned about the concept of the house of racism and explored 3 rooms in the house: intrapersonal, interpersonal, and white allyship. We learned that the house of racism has its foundations in colonialism, and its structure is maintained by laws, policies, guidelines, and rules. We learned that in nursing, structural racism reinforces the position and status of black and minority ethnic nurses at the bottom of the hierarchy. We also learned that internalised racism happens. My skin signals my difference and the impact that has on individuals. And that interpersonal racism is made up of microaggressions, micro-insults, micro-invalidations, and gaslighting. We also gained insight into the concept of international recruitment in connotation to slavery, namely the concept that international recruitment of nurses has similarities to slavery, and the notion of the transition from humanity to commodity, which has echoes of slavery also. For the international recruitment of nurses, Calvin has told us that the practice is already here, and the theory will follow, so let's make it a good theory, not like the one of the slave trade theory. And finally, we heard that not all white people are racist, and that BME nurses need to recognise the allies who hold the door open and invite them to the table. We learned that a white ally rises above silence and confronts racism as it occurs. We learned that white allies don't have it all figured out, but are committed and do not show complacency. We learnt that white allyship has a place in helping black and minoritised ethnic nurses to put down roots that reconnects their work with the British world that marginalises them. In terms of future plans and work, Professor Moorley highlighted that he'll be launching the Dame Elizabeth Annual Lecture for Inclusivity in Nursing and Midwifery with 5 awards, and that he'll also be developing the Calvin Moorley Centre for Inclusive Practice, which has a lovely ring to it, and we look forward to that happening. So I would encourage you to stay in touch with this important work and to continue to support Calvin in his future endeavours. I'd like to share some brief highlights regarding Calvin's dedication and expertise in EDI across the university. For those of you who don't know, he did mention it in his presentation that he's chair of the Race Equality Charter here at the university, of the self-assessment team. Calvin, in this capacity, leads several work streams with the aim of demonstrating LSBU's long-term commitment to cultural change in relation to racial inequality. In addition to this, Calvin is a member of the Athena Swan Committee for the Institute of Health and Social Care, with the purpose of furthering gender equality across the university. I would like to end with a few quotes that we've been given about Calvin from his colleagues. They're all good, don't worry. They are indeed. One colleague has said, Professor Moorley is an individual with a passion for learning and development, and his actions epitomise social justice by his efforts to improve the life chances of others. Another colleague has said, coming to terms with one's sexuality and living with your authentic self is challenging in any society, community and space. The space of self is uncharted and raises many issues, particularly for black men. Being able to reflect and review self so that one can live and practice that authenticity with pride of self and respect of others is an achievement of its own and to be commended. Another colleague says, Calvin has a passion for challenging inequality and inequity within both the NHS and higher education. He is well known for providing support and mentorship to both LSBU students and NHS staff, particularly those of African Caribbean heritage. One colleague has said, Calvin is my reverse mentor and gives me the courage to work through the really difficult work of being an anti-racist team. And finally, one colleague shares, he is always supportive of colleagues, but most importantly, he gives voice to the voiceless, which speaks volumes about the type of person he is. And these are wonderful sentiments to share this evening. I would now like to present Calvin with a memento to remember this occasion. Thank you very much, everybody, and we can now go ahead for refreshments.
Marcel, before we go, just one thing. I need to say one other thank you. Well, two thank yous, really. I won't be long, I promise. Just to say, Nick, you've been with me for God knows how long, feels like a lifetime, and from PhD to professor, so thank you very much for all your support. Free PhD, sir. And my family who's in the audience and those who are not here as well, thank you very much. You've all listened to me moan, and thank you for not bringing any sandwiches. But Rachel Picton, the dean of AHP, did send me a sandwich. and also one other person I want to thank. Whenever I have any plans, ideas to do EDI work, I run it past by him, and he says, no, it's not going to work. Yes, it will. And even, they're behind the scenes to get this Inaugural going is Neil Basing. And Neil, I really wanted to thank you. And I wonder if you'll come down for these. My true rock. Thank you. Oh, thank you so much.
Thank you.
Both things.
I'll kill you later.
And now we can have refreshments. Thank you all. Thank you. I'll see you outside in a bit.